Okay, welcome to Talking Data Equity. My name is Heather Kraus, and thank you so much for joining us. This is We All Count's regular, informal Friday drop-in gathering. We call it Talking Data Equity. And what this Friday series is a place for anybody in any sector, in any geographic location who is interested in embedding equity in your data projects to come and ask questions, learn new techniques, learn new skills, and hear about the work that various colleagues are doing across sectors and across countries. And every single Friday is different. That's the only thing that we guarantee you is that every single Friday will be different. And we do record these sessions. I'm going to put a link in the chat to the We All Count Data Equity Community Forum. And that's where you can go to find the recording from today's session and also to find the recordings from any other sessions along with linked resources. That's also a place where you can go to ask questions any time of the day that you're working on a data equity project, because there's people from all over the world in that forum that are happy to share their expertise, share their insights, share their successes, share their struggles. And that's not a membership site, it's public good. So hop in there anytime that you have a question or that you feel alone in your data equity work. And I guarantee you, you are not alone. What we are doing today is one of my very favorite things to do at Talking Data Equity. We have some special guests with us who have put some of their data equity ideas into practice, and they have been very generous to share their time with us to share their time with us so that we can ask them how it went and what they learned. And the housekeeping of this is that you can see that we're running this as a Zoom meeting, which means you are in charge of your own microphone. And we ask that while our special guests are sharing their slides and sharing their stories and examples, that you keep your microphone turned off and that you feel free to use the Zoom chat. You can ask questions in the Zoom chat. You can share reflections. You can talk to others who are in this session in the Zoom chat. And then if we have time at the end, depending on how the presentation goes, that's when we'll have an opportunity for you to turn your microphone on, ask questions, and share reflections. So that is the housekeeping. And for those of you who are asking, there's a couple of people who were here 2 weeks ago when we did a resource share who are looking for that link. I absolutely will share that link in the chat in a minute. And I will also let you know that that link can be found in the Talking Data Equity forum. So it's publicly available as well. Okay, so our special guest speakers today are people I have been fans of for a long time. We have three people who are going to talk to us about a survey that they've been doing for a long time and some updates and some changes that they've made that I know you all are very, very interested. So I am very excited to welcome Jamie, Lynn, and Stephanie. Jamie Stenberg is a band member of the Red Cliff Band of Lake Superior, and she serves as the research specialist for the Fond du Lac Band Tribal Institutional Review Board, where she oversees research ethics, data sovereignty, and integrity standards. Jamie works closely with the tribal communities and external researchers to ensure culturally respectful research practices and equitable data governance. And Stephanie studies exercise physiology at the College of Saints, studied exercise physiology at the College of Saint Scholastica in Minnesota and went on to get her master's of public health degree from South Dakota State University. And she's had the pleasure of working across a variety of roles within the field of public health, from pandemic response to food access work. And currently, Stephanie works as a program manager supporting 4 of the counties in Northeast Minnesota in implementing foundational public health activities. and she's part of an excellent team. And last but certainly not least, we have Lynn, who is a full-time faculty member at UW Superior Social Work Program for over 15 years, teaching the social welfare policy and macro practice courses. Lynn's expertise is in policy, advocacy, community, and organizational evaluation and change. And she also has 20 years of experience with human services research, primarily in the areas of mental illness and mental health. And in this capacity, she has worked with numerous local nonprofits and supported the extension of community mental health services in the Northeast of Minnesota and the Northwest of Wisconsin. So I'm going to turn it over now to Jamie, Stephanie, and Lynn with a huge thank you for the generosity of you extending your willingness to share with us for this hour.
Thank you so much, Heather. I'm going to start off by dropping a link to our project site in the chat if you'd like to check out more about our project as we get going today. So I'm going to screen share, and as soon as I get it set up, look to you, Heather, to make sure people are seeing the correct views here. Let's see. Full screen. Does that look all right?
That looks perfect. Yep.
Perfect. Well, I was first introduced to We All Count when I was working for a statewide food bank, and Heather did the Foundations of Data Equity training with the Feeding America Network. That was a couple years back, and anytime I've gotten a new email address or moved or started a new role, I just instantly go sign up for Talking Data Equity sessions and the newsletter so I can stay up to date with the amazing work that's happening at We All Count. So I am thrilled to be here today and share about a very collaborative project known as the Bridge to Health Survey and how we used the data equity framework from We All Count this iteration to make some enhancements. A little bit about me first. I love to travel. I have been living in the Twin Ports region, which is Duluth, Minnesota, and Superior, Wisconsin, for about 10 years now. I had moved away for a little bit with my partner, and we just really loved the Northland and came back. It's been a very chilly December, and so looks a little more like this picture right now. And we live in Superior, Wisconsin with our two dogs, Riley and Lewis. And I've had the pleasure of working in public health in Northeastern Minnesota in my current capacity for the past couple of years. If you're not familiar with the geography of the United States, Minnesota is right here, border Canada to the north, and Lake Superior shoreline here, and then are very close to Wisconsin. So we are a shipping port region, and a lot of folks come across the bridge to access healthcare for jobs, and goes both ways. So you'll notice we do cover Douglas County, Wisconsin in our survey as well. And Lake Superior brings about a big tourism industry. Folks are coming around to see the beautiful lake, and that fresh body of water does make us a climate resilient hub. We have Duluth, Minnesota as the urban region, and yet most of our region in the survey geography is very rural. So we have about 415,000 people in all 10 counties that we survey. We don't survey them all, but they live in that area. And our largest county has about 200,000 residents, and our smallest about 5,000 residents. And this isn't the entirety of our survey region, but it does highlight that we share geography with several tribal nations. And you may hear me use terms like Ojibwe and Chippewa interchangeably, or Anishinaabe, which is a broader name for Indigenous nations in the Great Lakes region. And I do that to really reflect the diversity of language preference within the Indigenous communities that we share geography with. The Bridge to Health survey is located on the traditional, ancestral, and contemporary lands of Indigenous people. It was cared for and called home by the Ojibwe people, and before them, the Dakota and Northern Cheyenne people, and other Native peoples from time immemorial. This land was ceded by the Ojibwe in an 1854 treaty and holds great historical, spiritual, and personal significance for its original stewards. And with this recognition, the survey team worked to honor the original peoples of this land, many of which are still here, thriving, and self-governing. And so we went through proper governance channels to ensure appropriate data ownership and stewardship along the way. And that's something that Jamie will share a little more about today. So what is the Bridge to Health survey? This is a survey that's been going on every 5 years since 1995. It began as a phone survey and transitioned to a paper survey in 2015. And the survey seeks to foster a greater understanding of health of the region's adult population and to motivate organizations and community groups to address pressing health issues and improve the area's health status. And we do this because we have a lack of local information on key health indicators. With state and national surveys, the data is often not representative of local areas, especially rural regions. And the sample size of statewide surveys is often too small to allow for community level analysis. So that's really the gap that we seek to fill with the Bridge to Health survey. And we also acknowledge that the state of data in the United States is ever changing, and some of the sources that have been historically trustworthy and reliable are now used cautiously. So we're aware of that context and feel that it makes local data more important now than ever. And we're working hard to ensure that we maintain community trust and support throughout the process so that we can be transparent, representative of the communities that live here, and have reliable data. A little bit about the 2025 iteration. So it was all the way back in April of 2023 that we did a cross-sector training with Heather on the foundations of data equity. And we wanted to make it cross-sector so that as public health is talking with community partners in hospitals or nonprofits, tribal nations, we're able to use some of that similar language and have similar understandings about these terms and where we're coming from in our approach. After that, we did Wheel Count coaching sessions with Heather, specifically dedicated to the Bridge to Health survey. The co-chairs for the survey began meeting in February of 2024 with our community kickoff meeting in January of 25. The following month, the action teams began meeting. These are open invitation teams, so anyone who's interested can come be a part of these. The data team ultimately selects the questions that land on the survey, and that's done through a consensus-driven process. The communications team works hard to get community representation and voices within the survey promotion so that community members are seeing people that they recognize talk about the survey and answer questions in a way that feels trustworthy. And then this time we did a BIPOC engagement team, BIPOC standing for Black, Indigenous, People of Color. And this was an additional sampling method added this iteration to help capture representative voices of those living in our region. It was really difficult for us in historic iterations to disaggregate data and really understand the story of health for these populations. And we tried some oversampling in the past and really realized we needed a more relational approach to this. So Lynn's going to talk a little bit more about what that looked like. And then in September, our survey distribution began. And you'll notice throughout this whole process was fundraising. This is a locally driven survey and locally funded survey. So different hospitals, public health agencies, and foundations work to fund this survey so that we can have local access to data. And of course, I mentioned this is a very collaborative process. I'd like to thank Generations Healthcare Initiatives for being one of the backbone agencies for a very long time for this survey, and all of those throughout the years who have contributed to this. So what are the ways that we really applied the framework to this survey? One of the things that we did was focus on enhanced transparency. So our website now includes a more obvious contact form for requesting data. So researchers and community groups can come in and request that, which is of course confidential and aggregate data that they can request. And a frequently asked questions page so that as people are getting the survey to their mailbox, they can go to that page to learn a little bit more about what is a survey, who's behind it, where does their data get shared, and where does it not get shared? Because we do try to add a lot of protections in place. And we also included more information in plain language in the welcome letter for residents. So we've noticed an increased level of concern about data security, and we really wanted to be proactive about addressing that. We also included more inclusive questions within the survey instrument. So we made our gender identity questions more robust and added a new question related to sexual orientation. We feel that because this is a local survey and we have local control, that we can safely ask these kinds of questions and make sure that it doesn't get linked back to any individuals and no identifying information gets shared out. And we also modified questions to make them more relevant across cultures. That was some of the great feedback that we got through this being a collaborative process. One example is when we asked about exercise, historically, we gave examples like golf and calisthenics. And we had some people say, I don't think I know anyone who does those things, but I do know people who paddle and dance and do yard work. And so we added those as some exercise examples instead. We also removed questions that put the onus for change on individuals and shifted it to asking more about systems. So, for example, we used to ask, how many fruits or vegetables did you eat yesterday? And while that does tell us some information, we really wanted to replace those questions and ask more about barriers to accessing food. So that onus for change is really on systems. And finally, we ask questions about feelings of unacceptance or discrimination so that we can better understand the level to which this is happening in our community. And we also ask about the settings that this is happening so that we can address them with systems involved. We also added a new sampling method, purposive sampling. So in order to capture more of those BIPOC voices throughout the community, we wanted to be more relational. So we worked with mutual aid groups, BIPOC run and serving organizations, tribal nations to help distribute the survey in a more relational approach. We were able to compensate those agencies as well as the survey participants. And the BIPOC engagement team was able to review the survey, offer feedback on cultural relevance, do a lot of research to help ensure that we were making some changes that aligned with our equity goals. And a special thank you to Blue Cross and Blue Shield of Minnesota for funding this sampling method. It was really helpful to have community support to make that happen. We also attempted to be more proactive in our tribal partnerships and approvals this iteration. I think we did a good job at that. Hopefully, we approached each tribal nation that we share geography with and asked them not only if it would be okay to sample on reservation tribal land, but also of interest to them. And so we were able to implement a number of data use agreements so that they would be able to maintain ownership and rights to that data. And we worked through the appropriate tribal IRBs or tribal councils to get those agreements in place. And we also worked with tribal health leaders to review the survey and offer feedback. So, for example, some of the tribal health leaders said, this would be so much more useful to me if I knew tribal affiliation or whether or not these respondents lived on tribal reservation land, because those are the people that we serve. So we're able to add questions about that so they can disaggregate that data. And that's something that they will own. It's not something we own. And after it's released to the tribal nations, it actually gets scrubbed as an identifier in our data set. So while researchers can request data from the Bridge to Health survey, they cannot request data that is owned by the tribes. They would have to seek tribal approval for that. And finally, we worked to pair it with resources. So we included 988, the Suicide Crisis Lifeline, after asking questions about suicide attempts and ideation. And we also included Resourceful at the end of the survey, which is the local resource hub online that points folks to low cost and free services related to food access, housing, and other structural determinants of health. So we're really proud of these changes that we've made, enhancements along the way, and I will pass it over to Jamie so that she can talk a little bit about the approach from the tribal IRB perspective.
All right, so hi everyone. I'm Jamie Stenberg. Like Heather said, I'm a band member of the Red Cliff Band of Lake Superior, and I serve as the research specialist for the Fond du Lac Band, which is located in northern Minnesota. My office is located in the Minoan Human Services Center in Cloquet, Minnesota. I obtained my Bachelor's of Science degree in social work at the University of Wisconsin-Superior. I worked as an on-reservation foster care licenser for 8 years, and I advocated for families that resided within the reservation boundaries. I switched my career focus to research oversight. I've been in my current position now for about 3 years. I have two boys, they're 8 and 10. In my spare time, I like to do beadwork. I sew regalia. I like to downhill ski in the winter, and in the summer, we like to go camping. I'd like to share some background history in regards to Minnesota and the associated tribes within. There are 11 federally recognized tribal nations in Minnesota. We are fortunate to have a high population of Indigenous people in our state. Out of the 11 tribal nations, we are the only tribe in the state that has a registered IRB with the Department of Health and Human Services, and we also have a federal-wide assurance. Each tribe is particular in the way that they conduct research oversight. Today, I'll be sharing information on the Fond du Lac Band's research review process and how we were able to work together with the Bridge to Health study team members. A little bit on my role as a research specialist. I manage the tribal IRB process. I conduct pre-reviews of research protocols and ensure that the research being presented aligns with tribal sovereignty and data governance principles. I help researchers through our approval process and also serve as a human subjects protection officer. As a protection officer, I'm responsible for ensuring that all research involving human subjects complies with the regulations and ethical standards set forth by the Department of Health and Human Services. This includes overseeing the IRB review process, ensuring informed consent is obtained, and maintaining confidentiality of research data. I also provide research ethics training for health in Indigenous communities to our staff, community members, and external researchers. You can go to the next slide, Steph. Before we dive in, I want to go over some key terms so people are familiar and not confused. So Indigenous refers to the original peoples of a region who maintain distinct cultural traditions, languages, and connections to their ancestral lands. Tribe, a sovereign, self-governing Indigenous nation recognized by treaties, federal law, or state law. A band is a smaller community within a larger tribal nation. Reservation is land set aside by the U.S. government for a tribe through treaties, statutes, or executive orders, where the tribe exercises certain governmental powers. An FDL is a Fond du Lac Band of Superior, and I'll use tribe and band interchangeably throughout the presentation. Some more, we have sovereignty is the inherent authority of tribes to govern themselves, make laws, and manage resources without external interference, recognized in treaties and federal laws. Our tribal jurisdiction is the legal authority of a tribe to govern and enforce laws within its territory and over its members, including civil and sometimes criminal matters. We have a tribal council, which is an elected governing body of a tribe responsible for making decisions, passing laws, and managing tribal affairs. It represents the tribe's interests, oversees programs and services, and exercises authority granted by tribal sovereignty and constitutions. Tribal resolution is a formal written action adopted by the tribal council or governing body. It serves as an official action that authorizes, approves, or directs specific activities, agreements, or positions on behalf of the tribe. Tribal resolutions are often establish laws, approve contracts, or grant authority for agreements. So I wanted to talk about traditional knowledge and traditional ecological knowledge. Traditional knowledge is knowledge, practices, and beliefs developed by Indigenous peoples over generations, rooted in cultural traditions and passed down orally. So some examples of that can be art and craftsmanship, like beadwork, quill work, birch bark canoe building. There's oral histories, migration stories, clan histories, creation narratives. There's kinship systems, clan structures, family roles and responsibilities, songs and dances, traditional songs for healing, seasonal dances, land-based skills like fire making, shelter building, snowshoe crafting, and values and ethics, respect for elders, reciprocity, and stewardship principles. Traditional ecological knowledge is a subset of traditional knowledge focused on the environment. It is a collective body of knowledge, practices, and beliefs about relationships between living beings and their ecosystem, developed through long-term observation and interaction with the land. Some of those examples are plant knowledge, identifying medicinal plants, sustainable harvesting techniques. There's animal behavior, migration, routes of deer, mouse, spawning of cycles of fish, weather indicators, reading cloud formations, animal behavior as seasonal signals, fire management, controlled burns to maintain healthy ecosystems. There's soil and water indicators, recognizing healthy soil, water clarity for fish habitats, and habitat restoration. There's traditional methods for replanting wild rice beds or protecting shorelines. So we have a tribal IRB process here at Fond du Lac. The external researcher will submit their study protocol with associated documents. I will conduct a pre-review and I'll give them some advice and recommendations. We'll determine a level of review, and we do go off of the common rule, which is 45 CFR 46. So because we are a registered IRB and we have an FWA, we do abide by federal guidelines that are set. After that, we do add a layer of tribal protections, and it may bump up the level of review. So sometimes we get a researcher from a university and their university might deem it exempt, but because there are cultural things that are included in the survey or the study, we might bump it up to an expedited or even a full board review. So it gets reviewed by the IRB. They may ask for revisions. Then they will fill out a research and data sharing agreement so we can own our data. And then there's final approval, which comes from our Reservation Business Committee, the Tribal Council. So I get to present all the research protocols that come through and present them to RBC, and then they do a final approval for all of our new studies. Also with the tribal IRB, any publications need to be approved by the tribal IRB. So then I want to go into the fair and care principles in tribal data governance, and these are guidelines for ethical and respectful data management. So the FAIR principles are, we have findable, which data should be documented and searchable, accessible, access under clear conditions, interoperable, is compatible with other systems, and then reusable, clear terms for reuse. These principles focus on technical openness and usability for science. And then the care principles, we have collective benefit, which data should support the well-being of the community. So health research results shared with Fond du Lac clinics for better care is an example. Authority to control, tribe decides how data is accessed and used. An example is the Fond du Lac IRB, approval required for all publications. Responsibility, researchers must respect cultural protocols. So for an example is a researcher destroying any traditional knowledge recorded by mistake. Ethics, data must align with tribal values and avoid harm. So an example is no dissemination without tribal review. To ensure Indigenous rights and sovereignty are respected, these care principles were developed. And the key difference, FAIR is about making data usable, CARE is about making data ethical and community-driven for the Indigenous community. So why this matters for tribal communities. So it protects cultural integrity protection. Example of that would be ensuring surveys avoid stereotypes or harmful language, or requiring IRB review for publication that references tribal traditions or ceremonies. Then we have, it supports self-determination. So an example would be a tribe decides what health is collected and how it is used to inform its own health programs. Another example is tribal council approves research priorities based on community needs rather than the external interests. And then addresses historical injustices. So historically, researchers collected data without consent and published findings that harm tribes. So we want to avoid that now. Modern practice data sharing agreements include tribal ownership and approval before dissemination, and then empowers tribes to make decisions. Fond du Lac uses its own subset of data to design culturally relevant health interventions, and the care principles ensure data benefits the community, not just the external researchers. Neat. So tribal data sovereignty, Fond du Lac ownership. Fond du Lac owns all project data and materials when data is collected from Fond du Lac band members, even if research occurs off the reservation. We get a lot of studies that come through that might be urban research from the Duluth area, but because there's such a high population of Indigenous, those research will come to Fond du Lac, and so we'll review that. When they're collecting a tribal affiliation, we want to have our own data for our own people. So we do those reviews to prevent any harm for our population. So we get the primary data, we get the surveys, interviews, biological samples, processed results, analysis data sets, products of research, reports, publications, photos, recordings, and physical materials, any specimens or artifacts. The researchers receive non-exclusive, royalty-free use for academic purposes. They must maintain confidentiality and obtain Fond du Lac IRB approval prior to any publications. Additional requirements is that they return all data and materials to Fond du Lac after project completion. They destroy copies unless otherwise agreed. Secondary use requires new IRB approval from us, and traditional knowledge must be returned immediately and destroyed. So my involvement began by meeting with the Bridge to Health team and conducting a pre-review before the IRB meeting to ensure the survey aligned with Fond du Lac's priorities and ethical standards. During these discussions, we made several important additions. First, we included tribal affiliation questions so Fond du Lac specific data could be identified. This was critical for ensuring our community's health needs are visible in the data. At the same time, we emphasize the importance of de-identifying affiliations in the aggregate data to protect participant privacy. We also addressed participant well-being. Because the survey included questions about mental health and substance use, we recommended adding resources for participants in case these topics caused emotional distress. Providing support options was an important step to making the survey trauma-informed. Finally, we worked closely with the Bridge to Health team to create a data sharing agreement that balanced research goals with tribal sovereignty. This agreement ensures Fond du Lac owns its own subset of data, controls how it's shared, and requires IRB approval for any publications. It also specifies that identifying information such as tribal enrollment and residence will be removed from the data set after Fond du Lac receives its own subset. In addition, any secondary data analysis or dissemination requires Fond du Lac IRB approval. And then the tribe retains the right to review and approve all publication. These provisions protect our community's data while still allowing researchers to meet project objectives. The Bridge to Health team also worked with other bands in the region, so each could receive their own data set. This empowers tribal communities to use their data to improve health outcomes and secure funding for programs that meet their unique needs. Overall, this collaboration reflects how research can respect tribal sovereignty while supporting community health goals.
And I just want to add that while the IRB process was not new to our team, the tribal IRB process was. So Jamie was just so incredibly helpful talking us through the process and what does this look like, and building a relationship with Jamie so we could really understand not only what's in the agreement, but why, and why is that important, so we can really look at including ways of just getting at those values through other ways in the survey too. So it was a great experience working alongside Jamie.
All right, in closing, our work with the Bridge to Health team demonstrates how research partnerships can honor tribal sovereignty while advancing community health. By embedding care principles into every step, we ensure that data serves our people first. This collaboration also shows what's possible when we commit to building stronger, more ethical partnerships, ones grounded in respect, equity, and shared goals. With that, I'd like to hand things over to Lynn, who will share more about the BIPOC engagement in the survey and how these efforts strengthen inclusion across our region.
Hi, everybody. Thanks for having me. I'm excited to talk about the work with the BIPOC engagement team. As Heather described, I am a professor of social work at the University of Wisconsin in Superior. I live in Duluth, Minnesota, and thinking about the map Stephanie shared, I drive across a bridge into Wisconsin and work at the university that Jamie is an alum of. I've got three adult kids and love to play in the snow and also love summer in this part of the world. So, and I'm from Alaska, which is a big part of my identity too. So I was fortunate to facilitate the BIPOC engagement team. And so my goal is to share with you the roles and protocols that drove our work, the process that we went through, some of the perspectives on health that we gathered and expanded our work. And then I do have the resources to share with you, but they will be in the presentation that will be available to you afterwards. So, but first of all, this was a very important part of the process from the very beginning. And so we invited community partners to participate with the BIPOC engagement team at kickoff. So it was front and center at the very beginning of the process. We intentionally sought representation from Indigenous partners and people that work in health equity roles and wanted to provide flexible opportunities for people to engage with our work. So if people couldn't come to the meetings, we would invite them to provide feedback in between the meetings. And I also offered to meet with people individually if that would be helpful. Our team composition was pretty fluid. We had about 6 people at each meeting, with some folks that were able to come at just about every meeting, but otherwise our composition was pretty fluid. And as Stephanie explained, we met opposite the data team. So we did meet twice a month starting in February of 25, and the data team would meet one week, and then the BIPOC engagement team would meet the next week. And then I was the sharer of feedback between the BIPOC engagement team and the data team. And then Stephanie was almost always at both meetings too. So if there was something that I needed to be expanded on or something, Stephanie and I would do that together. But there was intentional feedback from one group to the other group. And I want to highlight the concept that Jamie just brought up because it really drove the BIPOC engagement team process. And that is the idea that for the Bridge to Health survey to have a collective benefit, it needs to be collectively relatable. And so that really drove what the BIPOC engagement team was focused on. And so we started off by having intentional conversations with Black and Indigenous and people of color in the community about perspectives on health, and just wanted to hear from people how they identified health and what the factors and considerations were. And then we read and discussed 6 published sources about diverse perspectives on health. These are all referenced in this slide presentation. And that included 3 locally focused articles and meeting notes. So we really wanted to intentionally read any research that had come out of local projects that could provide perspectives on health that came from local community members. And so one was a research article written by American Indian Community Housing Organization that is located in Duluth and did research on COVID experiences with health during COVID. And another was also a research paper written by NAMI, our or not NAMI. Um, I just blanked on here, just one second. Um, Oh, it was COVID impacts on mental health, healthcare acts and access from the Black Community Needs Assessment that was published in the Journal for Equity and Health. And that was research that was gathered locally and published. And so we just in the last couple of years. And so we wanted to expose ourselves to that also. And then what we did was we identified key concepts from the literature, from discussions that we were having, and we linked those concepts with all of the survey questions so that we could identify questions that were relevant to the concepts or identify questions that needed to be modified to be more relevant to the concepts and perspectives of health that we were gathering. And so we intentionally formed recommendations for editing, adding, or removing questions to reflect these expanded perspectives. And we did a section at a time and a section at a time. And every 2 weeks, we would just kind of focus. Maybe it was on mental health, maybe it was on food security, maybe it was on systemic discrimination or experiences with providers. But every couple weeks, we would focus on a part of the survey. And then once we had all of our perspectives and recommendations incorporated into the new edit of the survey, we brought the revised survey to Indigenous health leaders, particularly to review and provide feedback. And then we edited the survey again based on that additional feedback. And as Stephanie mentioned, we then have engaged in purposive sampling that we have conducted with 7 organizations, one tribal nation, and then we have provided financial incentives both to the survey takers, but also for the organizations to support their efforts for outreach and survey facilitation. So I wanted to share just some of the relevant health concepts because this was key to everything that we did. And it includes concepts like Indigenous knowledge, cultural knowledge, intergenerational connection, land and kinship, environmental connection related to health, relationship, collectivism, sovereignty, autonomy, structural and systemic factors, social determinants of health, belonging, welcoming, cultural and traditional foods, gathering, medicines access, healing options, concepts related to safety and factors related to safety, rejection or respect for medical providers and systems, spirituality and access to ceremony, supportive conditions like basic needs, access to trusted information, and then mutual trust in medical providers. And this is the list of the resources. So I went ahead and included the conversations like the intentional conversations that were had, but also the research that we reviewed as a team. So you can kind of see there's a wide variety of information that we gathered really it took us about 3 months to go through the whole process of perspective expansion and then providing recommendations to the actual survey development. So lastly, I just want to share some insight gained and then make sure that we have a few minutes for questions. So this was, I will say, one of the most important projects I have been involved in my decades in academia and in community-based research. And partly it was the experience of having a long-time survey be willing and committed to expanding the protocols to demonstrate the the practices of data equity. And so it's not that we think we did everything, right, that we could have. There's things that we would do differently next time, but it was very refreshing to be a part of a project that was committed to principles of data equity. So I really appreciated the administrators being supportive. Um, and these are the four primary insights, I would say. And really, the first is about being flexible. And we needed to be patient. We needed to be slow in our work. We needed to be relational. We needed to be flexible with how people could provide their input. And we needed to provide many options to accommodate people because people are busy and we didn't want to exclude anybody's input because they couldn't attend a meeting. We needed to be ready to extend data collection timeline to accommodate survey distribution challenges and opportunities. And so we've even this week, we're extending deadline just to, because it's the right thing to do. And especially as the BIPOC engagement team facilitator, I have needed to just regularly follow up with community partners and just offer my time and ideas and problem solving to help them provide options for survey distribution. I'm driving to communities to pick up paper surveys if that works for them. Or we have QR codes, email. It's kind of like whatever works for people is what we want to support. And then the financial incentives we feel is a critical principle of data equity, both for the organizations and for the survey respondents. It is helpful, but it's also the right thing to do. So at that, I want us all to open our presentation up for questions and appreciate this opportunity to share our work with you all.
Thanks, Lynn. I wanted to add too with the being flexible piece that there were moments of discomfort within that, right? I mean, you might plan this beautiful agenda and your conversation goes in a much different direction. And you have this timeline of how it might work in your head and it shifts and shifts again. And sometimes conversations aren't really concrete. They're a little squishy and maybe the next steps aren't clear. And so just continuously coming together to see, okay, and where do we go from here? And is this what makes the most sense? And, making decisions together takes a lot of time and coordination. And so I think while there was the excitement of doing something new and different, there was also that like, take the deep breath and trust the process, or at least there was for me. So I just really appreciated, Lynn's steady hand and all of that, and just the whole team for that willingness to be flexible. And just before questions, really quick, I'll let you know where we're at now. We are wrapping up surveying currently. We'll be cleaning the data and moving through analysis with the University of Wisconsin-Superior folks as our data vendor, along with support from the Minnesota Department of Health on analysis. Of course, the data will be returned to those that we have a data use agreement with, and data will be scrubbed as necessary. And then we'll be planning our data conference and release in the spring. We've done that in person, we've done that virtual. And so if any folks have really great things that have worked for them in the past, data walks or artists to help us storytell, I'd be really interested in hearing more about that. And then we'll build out additional data dashboards and such as needed. Thank you.
Thank you so much, Jamie, Lynn, and Stephanie, for taking the time to walk us through the various sections. And you're absolutely one of the most inspirational teams that I've ever had the opportunity to work with, even just in the description of the amount of time. Like, I'm not sure that everybody just listening to your talk would understand how much time the three of you and another like large group of people just met over and over and over to talk about the nuances of how to embed equity in this survey. And it is very, very impressive the amount of time invested, rather than just kind of throwing up your hands and saying, oh, well, we had this 160-minute meeting and that's all we had. Is very, very amazing. So we have about 5 minutes. Is there anybody in the room that wants to turn their microphone on, ask a question, make a reflection? This is your opportunity to do that. You can either raise your Zoom hand through the reactions, or if you don't know how to do that, you could just turn your microphone on. And there's a couple of questions and reflections in the chat. And while everybody in the room decides if they want to raise their hand, I will summarize a couple of the questions that were asked directly to me to amplify, which was, can you tell us a little bit about if any of the sponsors or stakeholders were uncomfortable with the extending of the time frame? Like, did you have trouble with the time frame?
I don't know that we've heard any feedback related to that. I see one of my colleagues, Jesse Peterson, may be able to add to that. But it seems like the priority of having that reliable, locally driven data has been, the guiding light. And as you all know, if you've taken Heather's Foundations of Data Equity training, part of what you do is go through the purpose and identify, the restrictions that you have along the way. And what is your operational definition of equity? And so as we've gotten to decision points, we can go back to those things and say, this is most aligned with the purpose and our equity considerations and such, and move forward with that. So I think that's been really the biggest guiding light. I do think we have had some folks that have said, you know what, we use the word equity a lot, and I don't know what certain funders may think about that, so maybe just don't publicize,
Right.
which names may be a part of that. So I think there has been some sensitivity in publicly supporting the survey, although we know there is a lot of support, just the language restrictions that we're experiencing in the US right now.
Right. Sad, but true. Good point. Jesse, did we lose you? Do you want to share?
Sure. Thank you, Stephanie. Jesse Peterson. I am the director at Generations Healthcare Initiatives, one of the organizations, again, as Stephanie mentioned, that have been involved with this program for 30 years now. And I think, one of the pieces to just reinforce to this group, and thank you, this is so exciting to see this number of people on here, the importance of having a data project of this extent that's independent, that relies on that community support. But when I say rely, it's also because the demand is there, and the demand from this region to say independent, professionally developed research, and now this year that is so committed to an aspect of data equity in gathering this matters to us. And so we honestly, it's more of a challenge, I think, to remind ourselves that we get to set the timeline, and that what worked 20 years ago might not work this year, but we are committed to making this as successful, as robust, and as meaningful as possible. And I just commend all of our partners. We have over 40 financial sponsors and even more sponsors who were involved with the teams that have been described. So it is just testament that this matters. It really matters to people in the region, which is why we do it.
Thank you so much, Jesse. I think that amplification is so, so valuable, that this isn't an exercise in fulfilling some external funder's demands. This is data that immediately gets used to actually make decisions and improve the lives, and is in demand locally. Amy, go ahead.
Thanks so much. Really appreciate the talk. I'm sorry if there's some background noise here. I apologize if you addressed this at the beginning. I joined a little late. I'm curious just about This is kind of a logistical question, but it gets at a larger issue. What your like typical response rate is. Like for our traditional health surveys in my state, it is abysmal for like the traditional behavioral risk factor surveillance system. Um, and I imagine it's going to be worse with the current climate in the US. So just, and if you have addressed this, I apologize.
No, that's a good question. We've had some fluctuation over the years. Obviously, it used to be a phone survey, so that looks a little bit different than a paper survey. The highest response rate was actually when we sent it out in 2020. I think there were a lot of people at home with some more free time on their hands than they normally did. So I want to say the response rate was well over 25% that year. And so we do have a recognition that we might not get quite that response rate this year. In the 20% range is typically what we're looking for. We did notice a little bit of a slower uptick this year as we tried to first send out a QR code to save on some printing costs. And if that didn't work, send out paper copies afterwards. And there may have been a little bit of confusion over the QR codes. And we noticed paper is still doing the trick. That's what our community likes to see. So in some of our counties, we're already at that 20%. In some, we're slowly getting there. So that's about what the rate that we see. And Heather, I don't know if you can speak more to some of the trends you're seeing with other projects.
20% is fantastic. and the trends that we see directly relate clarity of purpose and building that trusting data relationship with increased response rates and the responses you do get being of high quality. So yeah, we will have to leave it there because we're really trying to respect everybody's time. This is such an amazing example of data equity at work that we could definitely hang out for the afternoon and talk about the nitty gritty and get into it. But we have to let you get back to the amazing work that you are all doing. And Jamie and Lynn and Stephanie, the details and the concreteness of what you walked us through today was tremendously valuable. We are so, so grateful for, first of all, you doing the work. And then second of all, for you making the time to come and share it with us. It's been truly inspirational and makes us all feel like we could reach this level too. And we are not alone. It is not futile. Data equity still exists. It still matters and is still being done actively one step at a time. So thank you so much. Again, this will all be shared and the recording will all be in the community data forum. So you can find it there. And thank you so much, Jamie and Stephanie and Lynn. Bye, everybody.